We're almost halfway through, so we've had 3 down and 4 to go. So when Dr. Collier is halfway finished, we will be exactly halfway finished with the conference. Our final speaker this afternoon is Dr. Kristin Collier. At the University of Michigan, at the University of Michigan Medical School, she is a clinical associate professor of internal medicine, associate program director of internal medicine residency program, and the director, I want to know more about, the director of the University of Michigan Medical School program on health, spirituality, and religion. Our special clinical interests include preventative medicine, primary care, depression, and heart disease. I bring this up hesitatingly, but I bring it up nonetheless. Like Dr. Plummer, Dr. Collier is active on X, or Twitter. And again, if you're not on it, don't start for this. But if you are on it, find her. She regularly posts reflections on topics around medicine and medical education and her faith. She clearly enjoys spending time outdoors, and she bakes some of the most beautiful breads. And so she's a very fun follow. Given her work in medical education, I know she'll be able to speak to the ways in which technology, particularly these artificial intelligence technologies, are already affecting medicine, even from the early days in medical school and on through into practice. So please welcome Dr. Collier.
Good afternoon. Thanks for being here. All right, I'm just going to get set up here. And team, if I can have my first slide, that'd be great. Thank you. All right, I'm really grateful to be with you here today, and thanks, Matthew, for the talk, the opportunity to give the talk. I've learned a ton about myself and the vocation of medicine putting the talk together. So my goals today are simple, but the task at hand is ambitious. I'd like for us to think deeply about the vocation of medicine and how it will be affected by the emerging technologies of artificial intelligence. It is easy for me to imagine that the next great division of the world will be between people who wish to live as creatures and people who wish to live as machines. Wendell Berry wrote these words at the turn of the century, and how prescient he was with his words. In a sense, Berry was looking out and asking, what type of people do we wish to be? Is it easier for us to look at ourselves as bio-machines in need of amending by science and technology? Because this seems to be the path we're on right now. Or do we see ourselves as human beings in need of healing? Right now, I believe we have dueling anthropologies in the vocation of medicine, and whichever anthropology we lean into will determine the type of medicine we will practice. One relies on technology to fix what is broken in the body, and the other relies on the humanities to heal the patient. These are 2 different types of medicine, and perhaps we need them both. But the question remains, who or what is medicine treating? And towards what end? We should note that the word medicine is classically rooted in the Latin word medior, which is a verb that means to heal or make whole in a very human, holistic sense. So based on the etymology of the word medicine, a doctor of medicine is literally a teacher of healing. This word medicine, we should note, does not share the same root as the English word mend, like mending clothes or mending bodies. Mending comes from the Latin word emendare, which means to correct defects. So definitionally, medicine primarily has to do with healing, not correcting or fixing. So right out of the gate, we can see how these distinctions in concepts and language are foundational to understanding what medicine aims to do. For if medicine is truly the art of healing persons, and is not solely aimed at fixing or correcting defects in the body, then already we're dealing with 2 entirely different anthropologies of medicine. And it seems to me that the fixing and correcting language, which is bound up in a machine anthropology of mankind, is the type of medicine we're more and more practicing today. So I have 4 questions in our productive wondering together this afternoon. Number 1, what should be the proper role of AI in our practice of medicine? Number two, how did we get here? To this place where medicine is replete with so many expensive technologies aimed at fixing the body. Three, what can we learn from Francis Bacon and his seminal work, The New Atlantis, about the situation in which we find ourselves? And lastly, what solutions do we have for a good and just way forward for our patients and therefore for our very own selves? Many of you are probably familiar with the lost city of Atlantis by popular culture. And some of you are aware that Atlantis is a fictional island mentioned by Plato, which represents the ideal nation-state. Plato, however, was not focused on technology in his vision of utopia, represented by the Republic, but was occupied with the ideal politically, seen through the lens of philosophy, not modern science. Plato's ends were not found in technology and health, but in the good life, what the Greeks called eudaimonia. In Plato's Republic, virtue, not bodily health, was the end of mankind. But that would change through the ages with the scientific revolution and the Enlightenment and the human project, which sought ends in mankind himself through progress. In 1626, Francis Bacon, English philosopher, scientist, and statesman, published The New Atlantis, an unfinished novel describing the discovery of a mythical island utopia in which the modern scientific method of empiricism thrived, being conducted at Salomon's house, a type of modern research university. Salomon's house served the establishment of science and technology. The end goal of the foundation called Salomon's house is, quote, the knowledge of causes and secret motions of things, and the enlarging of the bounds of the human empire to the affecting of all things possible, end of quote. Knowledge, secret motions of things, enlarging the bounds of the human empire, affecting all things possible. These certainly are bold ambitions for the ends of our humankind, and they are all bound up in technoscience, much like we see the ambitions of modern medicine today. In a word, Salomon's house is for progress. The goals of Salomon's house are different than Plato's Republic. In the New Atlantis, research and technology are the foundation of a good society, not virtue. The heroes in the book, The New Atlantis, were not politicians, but the inventors, makers of things, each enshrined in a hall of fame, each with statues, and they were given liberal and honorable rewards to the ends that mankind would be able to conquer the ill aspects of nature. Quote, diseases, plagues, swarms of hurtful creatures, scarcity, tempests, earthquakes, great inundations, comets, temperature of the year, and diverse other things, end quote. Bacon's vision is central to the goals of the scientific revolution in which we find ourselves today, living in the New Atlantis, executing the Baconian project. Think of all the promises of science and technology and all the progress we've made, but progress towards what end and for whom? So now to bring us to our current cultural moment, looking outwards towards the possibilities of AI in medicine, I'd first like to highlight a few of the scientific technological breakthroughs in the field of medicine, ones that I use as a physician all the time that got us here. The microscope. In 1590, a Dutch speckle maker is credited with inventing the first compound microscope. And in 1734, Yale becomes the first university to obtain such a microscope and employ it into its studies. The stethoscope. Stethoscope was invented in 1816 when a young French physician was examining a 40-year-old female patient who had shortness of breath. Dr. Laennec was embarrassed to place his ear directly upon her chest and perform auscultation. So he remembered a trick he learned as a child about how sound travels through solids. So he rolled up 24 sheets of paper, placed one end to his ear and the other end to the woman's chest. He was delighted to discover that the sounds were not only conveyed through the paper cone, but they were loud and clear. The X-ray machine. In 1895, a German engineer and physicist discovered X-rays. The first X-ray images in the US were published a month later at Yale, and the first clinical X-ray was taken at Dartmouth College that same week. The semiconductor. In 1947, Bell Labs team invented a semiconductor device called the transistor. It becomes a key piece of virtually every electronic device, including those used in electronic medical devices and machines. The computed tomography, or CT scan. In 1971, a radiologist in London performed the first CT scan of a patient in collaboration with engineer Godfrey Hounsfield, the technology's inventor. And as the technology gets more complex, the risks get more complex as well. The hospital. The modern hospital is a giant home for all these medical technologies in one place, a kind of medical technology supercenter for patients. Before all these expensive machines, medicine was practiced at the bedside in a patient's home, surrounded by family and loved ones, as portrayed in this really famous painting. It's an 1891 painting by Luke Fildus titled The Doctor. And it depicts a Victorian doctor observing a critical stage in a child's illness while her parents gaze on from the periphery. Note how Fildus omitted common medical equipment of his era in the painting in order to focus us on the relationship between the doctor and his patient. And now sick patients leave their homes and loved ones to come to a modern hospital because the hospital is where all of the expensive technologies and machines are kept in one place. And now AI. All these technologies have caused us to wrestle with how they change our work as physicians, wrestle with how we have relationships with our patients, and even the very definitions and scope of what we consider to be medicine. We are wrestling. Each technology along the way has sought to satisfy a goal of modern medicine, to answer this question: where is the disease? In the search for the answer to this question of localizing disease in bodies, however, there has been a justification of a retreat from the doctor, from patients, as persons each step of the way. I would say each technology removes us just a little bit more from our head directly upon the patient's chest for auscultation with the stethoscope. And perhaps now we are faced with the removal of our very selves, the physicians, entirely from the room with the patient. This shift in the practice of medicine via technology shifts diagnosing from a personal act to a scientific one. In modern medicine, it seems that AI is the next step along the continuum of bioreductionist medicine. Many see this as a good thing. Get that fallible, subjective human doctor and patient out of the way. Make medicine truly objective through machine analysis, free of human emotion and bias. But I am a primary care doctor, one who is patient-facing, who first comes to know patients as persons. My anthropology of patients begins with persons. Therefore, I first see medicine in a human way through my patients as persons living the life they have been given, and seeking meaning in their lives and in their illness. Most patients do want to be seen in the fullness of who they are and are dissatisfied with our current physical system that's often very dehumanizing and depersonalizing. But here we are in the 21st century, approaching a new era of invention with AI, machines, which many believe will be able to reign in an even newer New Atlantis, a utopia where computers will create new knowledge, inform new technological breakthroughs, make new discoveries, ones that were previously hidden or unknown to us. But to what end? Are the goals of AI even in line with the goals of medicine? If not, how can we prevent AI from changing the nature of medicine? I frequently say to our students and trainees about medicine, you are not technicians fixing complex machines, but human beings taking care of other human beings. Sometimes, yes, we can cure or fix people, but often we cannot. And many US adults are living with incurable chronic illnesses. We are not giving the public the medical professionals that are needed in our current era. People who know how to accompany people through chronic, unfixable, incurable illness. I think it's surprising to our students to learn that healing is still possible in the midst of incurable chronic illness and disease. But we aren't preparing students and trainees on how to do this, and machines sure can't do this. For us to understand why, I think it's important that we understand the difference between illness and disease. So disease refers to a specific pathological condition. It's a more objective term that refers to a specific pathological process in the body that often affects a particular body part or organ or system. Illnesses, on the other hand, are experienced in the person, spiritually, emotionally, and socially, as well as physically. And it is the patient's personal, subjective experience of disease, which we call illness. And we know that patients don't just suffer biomedical distress, but social, spiritual, and emotional distress, as pictured in this model by the mother of modern-day palliative medicine, Dr. Cicely Saunders. This is her model of total pain. And often, in my experience as a doctor, these other domains of distress, social, emotional, spiritual, experienced in illness, cause more suffering in my patients than oftentimes their physical disease. So to treat the disease requires knowledge, yes, but to treat the illness of the person requires all the knowledge of the disease, but much, much more. Treating the illness of the person also requires empathy, grace, wisdom, capacities machines do not have, and they will never have. Modern medicine likes to discount or discard the person's subjective illness, experience of their illness, in order to sometimes objectively fix the disease. But healing the patient of their illness requires much more. So Michael Foucault, who is famous for describing the scientific medical gaze that modern physicians often are taught, one of detached concern, describes how doctors modify the patient's story, fitting it into a biomedical paradigm, filtering out non-biomedical material, and totally discarding the patient's personal perspective, which is believed to be sort of tainted. AI in medicine is not a corrective for Foucault's medical gaze, it is a wholesale endorsement of it. Ironically, this clinical gaze is the triumph of modern medicine, because in reducing the patient to their body, we have learned many things about the body, but this has been at the cost of decoupling the person from their body. Now with AI, there's a risk of a further decoupling. Because machines can't understand persons, they can't understand illness. There is suffering in illness, in the persons who are ill. Machines don't understand persons such as sister, best friend, nana, people who are embedded within social structures, because machines are not persons. Not engaging with and recognizing and trying to relieve suffering in the person who is experiencing illness, only focusing on disease, is unjust and will only lead to more suffering. Machines don't understand human realities such as suffering, hope, grief. For the record, machines don't understand, period. Without understanding, any healthcare that machines provide will be by its very nature be void of understanding of theory of mind, sociopathic. Katerina Gospic, in her writing on AI and healthcare, compares AI to a sociopath, saying, quote, "A sociopath may have all the answers to curing your disease, but will be insensitive to your emotions and your personhood." She writes, "Your concerns about ethics, morality, and the pleadings for your life will go on deaf ears. The eyes and ears of the sociopath are distant, unblinking, and laser-focused. Due to the raw brilliance of AI, should we all fall to the feet of this brilliant sociopath and obey?" End quote. I don't know about you, but I do not want a sociopath to take care of my loved ones. I think of this picture of 3 of my 4 boys in Lake Michigan. I went into medicine to care for persons such as these, bodily persons with hopes, fears, and dreams, bodily persons made for higher purposes than bodily health. I think about this often when they're sick. I do believe that most of us went into medicine to take care of human beings, not receptors, not diseases, not symptoms, not parts of bodies. These physical parts of human beings are for sure important, but they do not take the place of the whole, the person, someone's sister, mother, husband, best friend, embedded in a life story. Patients are persons, not biological parts. However, paradoxically, modern medical education does not engage with the metaphysical concept of person. So the risk of this education, and the one that I fell into, was that you can come out of med school with a reductionist, mechanistic view of people, and ultimately of yourself. You can easily end up seeing your patients as just a bag of blood and bones, or viewing life as mere molecules in motion, losing sight of the person. So let's think about how this can happen. So for you scientists out there, I'd like for you to think about how exciting it was the first time you looked at something detailed under like a traditional microscope. The wonder of it. The science is really awesome and beautiful, and I'm so thankful we have it. I wonder what you looked at. Maybe the skin of an onion, a drop of blood, a splash of pond water. So I'd like for you to picture yourself now maybe in a med school histology lab, looking at a slide of human tissue under the microscope. What has to happen for you to look through that microscope? One eye has to be closed to look through the microscope at the cells on the slide. What you see looking through technology with that one eye closed is the scientific world. But now I want you to picture yourself now looking up and opening both eyes to really see. And you're in the patient's room, gazing at the patient, this person lying in the bed in front of you, whose cells you were just investigating. And he looks back at you and he says, "Please help me." What's needed now? You, of course, must look at him with compassion, with both eyes open, person to person, and provide care. Medicine needs to be a both eyes open type of vocation. People are more than their parts. They have inviolable worth and inherent dignity that we only see with another eye, another lens, our Christian one. And this lens cannot be informed by modern science. So what I hope to get across, which is what I've been laboring on to build my case about AI in medicine, is that modern medicine in its technoscience approach often teaches you to look at patients with only one eye, through a purely scientific or technical lens, and this leads us to lose sight of the patient person in front of us, the one we went into medicine for, the one we are called to humanely heal. Philosopher C. Stephen Evans, in his work, Preserving the Person, A Look at the Human Sciences, says it this way. I think this is really pretty. Just as poetry is not a collection of letters that make up parts of words, so too is a person not a collection of cells that make up parts of the body. Perhaps the physician should not be understanding the person from the body, but should be understanding the body from the person. Refocusing on the person in patient care shifts the physician's focus about the body back to the person. This shift does two very important things. One, it establishes medicine as primary caring for persons. And two, it reestablishes the primacy of moral agency for health back to the person. Reversing the primacy of focus to the person first places the horse properly before the cart, so to speak, and rehumanizes medicine. But our current retreat into scientific reductionism leaves the person who we are supposed to care for in medicine behind. So in clinical medicine, I've seen recently diagrams like this. This one is from a piece by Kristin Collier in Frontiers in Medicine, which shows AI as being in relationship with the patient and physician, a partner in healthcare. This is a huge shift in how we view the proper place of technology in the patient to doctor relationship up to date, one that changes the nature of medicine. Up until now, the patient-physician relationship has been a very sacred dyad, one of personal confidentiality and trust. In my opinion, we should be very, very careful about who or what else is allowed in that sacred space of the doctor-patient dyad. I know the phrase patient-centered care is all the rage right now, but I prefer the term relationship-centered care. We know that longitudinal good relationships are actually a patient safety issue. For example, I can recognize first if one of my longstanding patients maybe looks a little bit off, more so than a colleague would who had never seen that person before. And oftentimes that can be the first sign of something really serious going on with them, either physically, mentally, or socially. Additionally, good relationships in primary care have been shown to be predictive of good medical outcomes. I'm so protective of the trust in my office, in this space, that I have not even accepted a medical scribe into my exam room to take notes or to dictate for me. And I'm so aware of the potential disruption in the relationship between the person-to-person encounter that I don't even allow a laptop between me and my patient. So here's my first point, which is the main point, really. Medicine is fundamentally a person-to-person vocation. Physicians examine bodies of persons, yes, but anthropologically, we are taking care of persons, not bodies. The theologian Abraham Joshua Heschel warned us about taking our eye off the ball, the patient person, during his seminal address to the American Medical Association in 1964 in a program entitled The Patient as a Person. In his remarks, he talked about medicine going from a practice to a production, and the resulting disenchantment that follows. In this model of medicine as a production, the human personhood of both doctor and patient are marginalized when the physician focuses on the physical body alone. In this model, quote, personal medical practice on ill persons is exchanged for impersonal technical production on ill bodies, end quote. This failure is due to the loss of awareness of what it means to be a person, of what it means to be human, and to the distortion of the concept and image of being a doctor, frankly. This failure harms both patients and physicians. So to give you an example of what I believe an impoverished, disenchanted model of healthcare looks like based on what we've so far discussed, I'd like to refer to a scene from the 2016 American sci-fi film Passengers, starring Jennifer Lawrence and Chris Pratt. So for those of you unfamiliar with this gem, this movie is about a spacecraft carrying thousands of people to live in a new colony in space because Earth has become uninhabitable. The problem is that the new colony is very far away, and therefore all the passengers are placed in a deep hibernation state so they don't die before they reach the new colony. And the pesky machines falter, and this leads to both Lawrence and Pratt waking up out of their hibernation about 90 years too early, which leads to some interesting ethical questions. So in the movie, the ship's captain, played by Lawrence Fishburne, also gets awakened out of hibernation, and he becomes really ill. So in the sick bay of the ship is a complex, sophisticated machine. So Lawrence and Pratt take Fishburne to the sick bay, and they place him in said machine. The machine quickly and efficiently scans him and outprints a list of all the things wrong with him. And then from another slot in the machine, some pills are dispensed. And we see Fishburne take them in his hand and look at them quizzically. And the next thing we see is Pratt and Lawrence pushing his dead body out of the spacecraft into space, and he floats away. Is this your ideal vision of healthcare? If not, why not? What's your problem? Like, he got the right diagnoses, all very accurately and quickly, I might add, and the evidence-based medications for what he had. The pills he probably got were maybe a mix of palliative sedation and maybe some pain relievers. So why is this scene so disturbing and dystopian? It's because there is no care in the healthcare. Here was a man who was frankly diagnosed with his death, and no one was there to hold his hand while sharing the news, or ask about or addressing his likely existential grief, or anything else that good medicine should be. Again, the diagnosis and treatments are necessary, but insufficient for good healthcare. In seeing the human first through my human eyes, and hearing the human through my human ears, I have developed an interest in something called narrative medicine. Many of you are probably familiar with narrative medicine, which aims to recover meaning in medicine for both patients and physicians by reclaiming the value and use of stories in healthcare. As the founder of the movement, Dr. Rita Sharon has said, the care of the sick unfolds in stories. The point here is that the humanities are essential to patient care, and machines are not equipped to deal in the humanities in any fashion. The person who is suffering illness within a life narrative matters immensely in medicine. So we must see the person, hear their stories, talk to them, and not rely solely on machine scans and blood draws. And when I talk about the benefit of therapeutic listening and bearing witness to suffering in medicine, I often use this really beautiful sketch of Job and his friends. It's by Gustave Doré. So this shows Job being attended to by his friends. They aren't fixing, doing, curing. They're bearing witness to suffering, which in itself is a therapeutic act. Machines can't do this. Why? Because machines are dead. So now let's get into specific tasks at hand in medicine and consider how AI might assist in medicine. So let's talk about the art of diagnosing and prescribing and treating. We'll start with the art of diagnosis. Before I went to med school, in my mind, I thought clinical medicine was mostly spent on the art of diagnosis. But as a practicing physician, I realize it's the least of what I spend my time doing. Also, there is much talk about AI having predictive powers, where it would be able to predict your risk of a disease based on population data, genomics, et cetera. This will lead to an ever-expanding disease record as we will give people more diagnoses. Think about if AI is used in modeling future disease probability and how this would expand our diagnostic scope of pre-disease and disease. An ethnographic study as described in this recent paper by Dr. Marks in the Annals of Family Medicine found that, quote, patients with pre-disease, like pre-diabetes, pre-hypertension, perceive themselves as ill, equating risk with disease, and physicians and patients viewed intervention as treatment, not prevention. Aggressive treatment of at-risk conditions fulfills the illusion that healthy people are sick, end quote. If a patient thinks they have pre-heart disease or pre-cancer or pre-diabetes, they are given a probability and a timeline. This creates anxiety and illness in the patient now. This is bad medicine. So in this sense, medicine with its overemphasis on diagnostic models and predictions and risk forecasts is making people ill. This is the modern health problem that has been created through science and technology, gutted of the humanities, which finds disease everywhere and in everyone. We need to push back. We're coming to a point where overdiagnosis is becoming absurd and the whole world is becoming sick. This is not good medicine. This is just one example of how we overestimate the value of the technical aspects of medicine and miss the mark. For example, a specialist for a patient of mine was frustrated that the patient kept no-showing for an EMG test at the hospital. The patient was rescheduled after each no-show, but she still refused to come. What the specialist didn't know is that to receive the testing, she would have had to walk through the children's hospital where she lost a child 10 years ago to congenital biliary atresia. And because of her trauma in that space, she couldn't bring herself to go there. I have a patient who has a clear and known diagnosis of heart failure. The diagnosis is not in question. But he has periodic exacerbations that often baffle the admitting teams. But as his primary care doctor who knows him, I know that each time it happens, the most likely cause, i.e. diagnosis, is because his wife, Ruth, who cooks for him, goes out of town to visit her sick sister from time to time. And then he has to rely on fast food or processed food to eat, which puts him into failure due to the salt load he ingests. Or a patient of mine who has recurrent abdominal pain, not because something's inflamed or infected or blocked in her abdomen, but because she has been a victim of intimate partner violence. Or that a patient of mine at the end of his life who had refractory nausea that wasn't responding to medications actually had unrecognized spiritual distress. And once we got appropriate pastoral care for her, her nausea abated. If you don't know the person, patient care is impossible. It's not possible. The wise William Osler summarized it up best when he said that it's more important to know what sort of a patient has the disease than what sort of a disease the patient has. So we've talked about diagnosing illness versus disease and the focus on persons, but what about treatments? Can AI help there? Think about how often guidelines change. It's hard, right, to keep on top of all the new medications for diabetes and COPD and asthma, all the biologics, et cetera. Won't AI be of help there? Well, effective treatment is also much more than knowledge. Lack of knowledge is not the problem in effective healthcare delivery. To give you an example, there was a study done on adult primary care patients with type 2 diabetes, looking to see what factors went into them being able to have control of their diabetes. And after controlling for several factors, including the medical knowledge of the physician, the most important factor for getting the patient's diabetes to be controlled was the communication skills by the physician and the relationship between the patient and their doctor. Relationships heal in medicine. When it comes to treating and caring for patients who are sick, the healing process, let us never hand that over to dead machines. Let people care for people, not machines. But the great irony of medicine in our modern era is that physicians and healthcare workers are surrounded by machines. They're everywhere in hospitals, so it's all too easy to lose sight of humanity in these places. But the technology without the person is useless. I think of the stethoscope I showed you at the beginning of, for example. I always remind my students that the most important part of the stethoscope is this part between the ears, right? The stethoscope's like a loop. You can have the most expensive stethoscope in the world, but if this part between your ears is not sort of developed, the technology is totally useless. So I need to interpret what I'm hearing, make sense of it, and then apply what I hear to the patient in front of me. And philosophically, this brings us back to the root of medicine. What is medicine for? Is it solely a Baconian project for attaining biological health through knowledge and technology and invention, or is it the practice of medicine something totally else entirely, something we're losing? In this piece that I wrote, What is Medicine For? It was published in the British Medical Journal last year. I explored the question of what medicine is for and called for a return to thinking about the goals of medicine as being ones grounded in human flourishing of human persons, a fuller definition of health. I ask, quote, is medicine only concerned with bodily health as the final good of the profession, or does medicine further encompass the health of the person aimed at virtue as its final good? I believe medicine needs to become wise and recognize the latter and own up to taking care of human persons and not just bodies. In our goals of providing relationship-centered care in primary care, we must not resort to making decisions for patients based on algorithms, big data, etc. In addition to creating illness, doing so just doesn't take into account higher goods in patients' lives to which they are beholden. Think about the virtues such as service, self-sacrifice, love, or the vices of selfishness and hate that often cause patients to subvert their bodily health. Think of a pregnant woman who chooses to delay the initiation of life-saving chemotherapy for a newly diagnosed cancer while she's pregnant in order to preserve the life of her in utero baby. Healthism is not the end goal of medicine because healthism is not the goal of human persons. Given this, what's one of the most important attributes to provide good medical care that a machine will never have? Wisdom, or phronesis. David Wiggins writes about the role of wisdom, which I believe is an important ingredient in good medicine that's not healthism. He writes that a person with practical wisdom is, quote, able to select from the infinite number of features of a situation those features that bear upon the notion or ideal of existence which it is his standing aim to make real. In no case will there be a rule to which a man can simply appeal to tell him what to do, end quote. Our patients see the world through competing goods, and it's our job to understand those competing goods and help guide them towards those goods which are most aligned with human flourishing. This requires wisdom on behalf of the physician in relationship with their patient, something which isn't often taught in medical school, and something AI will never be able to do. So, for example, take a woman with a history of antiphospholipid antibody syndrome. This is a condition that can make you sort of bleed and clot. It's very high risk if you were to become pregnant. And maybe she wants pregnancy. And she asks you, should I become pregnant? Should I consider getting pregnant? How would an intelligent but unwise machine respond in her case? How would the general knowledge of the machine be translated into a particular wisdom for the patient? This translator is wisdom, right? Something machines do not have and can never have. While machines for sure can be programmed to maybe give medical advice, the particular context of the patient's decisions are made in domains larger than biomedical health. Consider the transcendent personal goods, such as in our earlier case, wanting to subvert one's own physical safety for the higher good of bringing another life into the world. How does a machine make sense or use wisdom in guiding that patient? It can't. It can't because the machine cannot become wise. And as Professor Catherine Tillman has written, quote, wisdom is not something that exists in isolation from others. Practical wisdom can no more exist in isolation from the discursive community that constitutes it than an individual can have self-definition or reality apart from it, end quote. Machines are not embedded within human communities, nor can they ever be, therefore they can never become wise. Wisdom, over and above intelligence, particularly artificial intelligence, is what is necessary for the practice of good medicine. But why is this shortcoming of AI, which is lack of wisdom, not being more decried in our conversations of medicine? It's because the pathway has been laid forth and wisdom has been marginalized in the practice of medicine. Our focus on evidence-based medicine, algorithms, and a provider of services model has paved the way for us to be in the situation we're in right now. We don't see wisdom as necessary or invaluable in the good care of patients. Without wisdom, the patients will be lost. So we've talked about how machines are apersonal and amoral and non-human entities that are unwise, and they can't understand persons and their metaphysical commitments. These are some of the primary deficiencies of adopting AI into healthcare, but what are some of the additional threats? Well, to patients, there is a risk of continuing to blur the line in our anthropological frameworks, and this is something I'm especially concerned about. This theme has already been addressed by several speakers this weekend, so I'll keep this part brief, but you've all heard or seen in our sci-fi movie history, or even in pieces like this in First Things, a call for alarm about the impending machine apocalypse. And even in our cultural imaginary, there's some kind of fiery doomsday scenario where the machines finally take over the world. But what if the apocalypse comes slowly? So slowly and insidiously that we fail to notice it until it's too late. I do believe that's where we're at right now, a slow chipping away at our idea of what it means to be human, and a blurring, intentionally or otherwise, of our anthropological identity with that of machines. This may be the biggest threat of all, that AI has the capacity to undermine our understanding of the human person and paves the way for a post-human future. Copious use of technology in medicine in the place of humans runs the risk of marring the image of God by degrading the anthropology of human beings. A medicine which cannot or does not recognize the imago Dei is less than humane. The other problem and threat that I see with AI in medicine is the de-skilling of the medical doctor such that they will no longer be able to teach nor practice scientific medicine as we know it today. I think here of this very popular book a few years ago by Dr. Grootman titled How Doctors Think. Doctors are trained to think in a certain type of way, and that learning of how to think is formative. It gives shape to us. Again, there's great irony in leveraging technology such the artisan loses his skill to that technology he creates, or with medicine that AI would cause the physician to lose the scientific knowledge by forfeiting it to the machine. In education, we've already seen the eroding of the memory of students, whereby smartphones are used to supplant their own memory. I foresee the same thing happening within medicine, where the intelligent training of the physician will be forfeited to the machine. We all think that our own memories will remain intact after leveraging new technology, but we are naive to think so. Here I think of Socrates when he delivers a condemnation of writing. He says, "It will produce forgetfulness in the minds of those who learn to use it because they will not practice their memory." Their trust in writing, produced by external characters which are no part of themselves, will discourage the use of their own memory within them. You've invented an elixir, not of memory, but of reminding. And you offer your pupils the appearance of wisdom, not true wisdom. For they will read many things without instruction, and will therefore seem to know many things, when they are for the most part ignorant, and hard to get along with, since they are not wise, but only appear wise. I think of the medical students and what is at stake in med ed if we lose a generation of physicians who will lose the embodied knowledge that's been passed down to us for a very long time. But I've heard students say, "Oh, AI will save us so much time, will help so much, it will take the patient's symptoms and spit out the diagnosis, and then we can spend all this time with patients." So this slide shows the ChatGPT interface, which I'm sure you're all aware of. First of all, there's something integral to who I am as a doctor in my ability to create a differential diagnosis through clinical reasoning. Being able to correctly diagnose a disease is necessary to being able to treat that disease. Decoupling diagnoses from treatment is a risky dualism in medicine I don't think is really clinically sound. This very process of learning to do this, to diagnose and treat together, has shaped and formed me as a medical person who takes care of other patients. This learning process, which was really hard and necessary, this work of becoming a doctor, is what has shaped me into who I am as a medical doctor. I can't imagine becoming a doctor not having learned how to become a doctor. But our medical students are very excited about using chat to help them solve the cases we give them to think through. It's because they are focused on the answers, instead of realizing it is in the process of thinking through the cases that shapes you into becoming a doctor. If you stop thinking like a doctor, are you even a doctor? Learning is not some filing cabinet of knowledge we access, right? But literally forms us into who we are, doctors. Can we forfeit this learning and still be doctors? For example, I've heard that some of my colleagues, when they're dictating their notes, They don't just jump to the treatment plan or conclusion, but they go through the clinical reasoning in the note, dictating out loud, right? They reinforce the habits of clinical reasoning out loud, keeping that physician clinical reasoning skills intact and embodied. I've also seen what happened recently, you probably know about this, when a really prominent health system in this country got hacked and their EMR went down. They had serious trouble taking care of their patients because they were so dependent on those machines. What if we de-skill physicians from being able to create a differential diagnosis and the machines go down? Plus, the idea of machines freeing up time that will be given back to us, I think that's super naive. I have colleagues who use scribes for their documentation, which does save time, and those providers are asked to see extra patients during the day. No time's been given back to them. I also have serious concerns about AI further worsening health disparities, as written about by FACP, Payton, and Scientific American last year. Patients and people with means will retain human physicians who are well-trained in the ancient skills of clinical reasoning, physical exam, and history taking, and relationship-centered care. The wealthy will get this, and the rest of us will receive machine medicine. Okay, so for the end here, hopefully I've provided some serious concerns as these threats to both providers and patients that AI could bring. Beyond the anthropological debate, the de-skilling of physicians, and increasing healthcare disparities, there are countless other problems we don't have time to get into with adoption of AI. The lack of a coherent locus of ethical and legal responsibility, further risks of bias, excessive energy consumption, increased regulatory costs, privacy concerns, increased technology costs. So why isn't there more concern? Why are we buying into AI with such unprecedented, unbridled enthusiasm? Why don't physicians and patients resist? Well, first of all, we don't know how. Secondly, given the first reason, we don't believe we have a choice in the matter. Because we've relegated the humanities, including philosophy and the love of wisdom, to the margins of medicine and patient care and replaced them with science and technology, we have lost our moral vocabulary and imagination in medicine, and therefore are ill-equipped to handle the philosophical and moral challenges posed by AI in medicine. There's already been a thinning of ethics in academic medicine over the past couple decades, if not longer, where discussions about goods and ends have been largely displaced by a discussion about means and progress. If you talk to healthcare workers and physicians about human ends and the goals of medicine and use terms like goods, they honestly oftentimes don't know what you're talking about. We don't like limits. As writer Jessica Houghton-Wilson wrote recently in Notre Dame's Church Life Journal, human beings have never been good with limits. Eat of every tree, except that one. And medicine is no exception. Again, when Bacon writes about the goals of the new Atlantis, he writes, "The end of our foundation is the knowledge of causes, secret motions of things, and the enlarging bounds of the human empire to the effecting of all things possible." This seems like a call against limits to me, and a call that modern medicine has taken up as a mantle. We're also afraid of going against progress. Mary Harrington's book, Feminism Against Progress, was hands down the best book I've read this last year. In it, she pokes holes at our collective idea that progress is always a good thing. She writes, quote, "Pick any subject, and you'll find that what looks from one vantage point, like progress, mostly seems that way because you're ignoring the costs." What are the costs of AI in medicine that we're ignoring? We're also increasingly at the service of the market. Good ethical medicine should never be at the service of the market. Pragmatism, consumer desirability, and economic driving forces are often the major factors, as you know, in technology adoption. But for those of you who work in academic medicine, there is something distinctly challenging about working against the powerful inertia of the academy and mustering the strength and withdrawal to be a dissenter. Here, I think of this piece that Carl Elliott wrote in the New York Times. He writes, quote, "Medical traditions are notoriously difficult to uproot, and academic medicine does not easily tolerate ethical dissent. One of the great mysteries of human behavior is how institutions create these social worlds where unthinkable practices come to seem normal. Groupthink, the forces of social conformity, are especially powerful in organizations that are driven by a deep sense of moral purpose. If the aims of the organization are righteous, its members feel it is wrong to put barriers in the way," end quote. The late Dan Callahan of the Hastings Center questioned the idea of endless medical progress. About him, Voices in Bioethics said, quote, "He challenges the widely held assumptions that there is an absolute moral obligation to conduct scientific research and that new technologies will always better our world," end quote. He also said it's the role of the field to be a loyal dissenter. That's what I'm trying to be, and that's what I would ask all of you to be here as well, my fellow colleagues and friends. I think of one final solution. In addition to the individual people like you being voices of concern within your own spheres of influence, it'd be some type of resurrection of the President's Council on Bioethics with an expanded scope to include AI. So as you probably know, on October 30th of 2023, President Biden issued an executive order on AI, but provided no framework for the goals of AI outside of consumer protections for safety and data security and responsible legal use. The goal of human flourishing in any context is remarkably absent from the directives. Writer M. Anthony Mills, in this wonderful piece in the journal, The New Atlantis, argues that under Biden's approach, quote, the language of federal regulation is ill-suited to the task at hand. Its moral vocabulary is too narrow. A narrow focus on regulatory tools risks obscuring more fundamental questions about ends, not just means, thus depriving us of the moral resources needed to grapple with the challenges and opportunities we're likely to face in an age of AI, end quote. So President George W. Bush offered, as you know, a different model of technology governance and healthcare when he issued an executive order establishing the President's Council of Bioethics in 2001, but that order expired in the fall of 2009. The Bush panel was unique in that it was a panel of experts led by Leon Kass that aimed to educate and inform lawmakers and the public, and its members ranged from legal scholars to philosophers. Mills calls in the piece for reviving the President's Council's approach to re-engage lawmakers and the public to invigorate public debates about these emerging technologies and bioethics. These discussions, of course, would be rooted in scientific technology and their intersection with the humanities of philosophy and ethics, even religion, with the broad goal of human flourishing. I would pray that such an approach is reborn. And lastly, undergirding all of this, we need to reclaim a role of wisdom through the humanities and medicine to inform our science and technology towards better ends than progress. The humanities, having been stripped away from medicine, means we have little understanding left of human beings and health, frankly. We don't prioritize them. For example, categories of NIH funding are all by scientific disease, the negation of health. It's an odd irony that a positive view of health, the goods of family life and community, higher purposes and virtue, one seen through the humanities, philosophy, and religion, these are attributes of health and well-being, but modern scientific medicine refuses to acknowledge them in any meaningful way. The following aspects of the human condition directly impact your health and the health of your loved ones: family relationships, education, religious upbringing, morality, conscience, and much more. Yet all of these confounding factors of health and disease are generally excluded from the purview of modern scientific medicine. If this is the case, then much of our current patient-lived phenomenon that contributes to both health and the disease in the body cannot be explained from a purely scientific perspective. This means very real human confounders of health and disease in patients are knowingly and willingly being excluded from medicine's study and medicine's care. Did you know that in 2024, the NIH budget was $47.1 billion? That's a huge number, and it covers 324 research disease areas. However, there are 0 discrete categories of funding related to the humanities, religion, spirituality, family life, morality, and such. Even though physicians and patients fully acknowledge that these factors are huge and powerful confounding variables in their patients' health and disease. Against this backdrop, we find that AI and machine learning were granted $2.1 billion in 2024, already 5% of the total NIH budget. Seems to me that AI is the classic case of a technology solution looking for a problem to solve. In response to the total disregard by the NIH for prioritizing the humanities in healthcare, we need more individual physicians to become comfortable going against the grain, to embrace the humanities in our patient care, and to advocate for public funding for this work. There have been some calls for this of late by some scholars like Lisa Cosgrove here, who writes that when you cultivate phronesis or wisdom in medicine, this will help physicians to become irreplaceable. To the extent that medicine cultivates wise doctors who practice wise medicine through wise person-to-person care, incorporating the humanities as important confounders of health, medicine will be good, and AI then should be kept in the proper place outside of direct patient care. And to end, I think it's only appropriate here to end with Cass. Quoting from his piece, Ageless Bodies, Happy Souls, Cass says, quote, Decisions we today are making will shape the world of the future for people who will inherit, not choose, life under its utopia-seeking possibilities. He says, it is up to us now to begin thinking about these matters. Thank you.